Hi, Matthew Holt with the Healthcare Blog. Here with Brian Yarnell. Brian is the president of Bluestream Health, but I'm interviewing him a little bit about his history here in the world of tech startups, because when we first met, Brian was one of the first round of people, of companies, with a company he was then CEO of called Starling, which was in the first round of what was then called the New York City Pilot Health Tech system. So, Brian, you moved on a bit since then, but real quick before we go on to Bluestream, what does Starling do, and what happened in the end?
Sure. So Starling was a replacement for Nurse Call. That instead of pushing those old-fashioned buttons that light up a light in the hallway, we presented users on a touch screen the most likely items that you would ask for, and we adapted that based on the patients. So the language they spoke, where they are in the hospital, with the goal of being able to cover off 80% of what you need in a hospital bed within just 2 clicks. So it was very much a workflow-focused product where we were making sure that people got what they needed in hospitals very quickly, very efficiently.
And what happened to the company?
So that company we sold to Hillrom, who's a major manufacturer of things like Nurse Call, believe it or not.
And beds and other stuff in the hospital system. So relatively rapid turnaround, quick successful exit there. And then instead of retiring to the beach or whatever a rational person would have done, you found another problem in hospital communications. So what was that?
So that's our current product, Bluestream, or the current company. That one, the inception for that was kind of interesting. A gentleman that I'd met named Matthew Davidge had also sold a company about the same time and acquired a sign language interpreting business. He knew I had some time on my hands, approached me to try to find what we kind of naively thought would have been very simple, a light, easy to deploy solution to deliver a remote expert on demand to the bedside. So I traveled around the country with Matthew, and we looked at all the existing telehealth and video conferencing and interpreting systems and came to the conclusion that we really couldn't find something that, very inexpensively, very flexibly provisioned relationships on the fly between someone at the point of care and a provider. So of course we had the bright idea to found Bluestream and solve that problem.
So, that is quite the question, right? So really, there's all these telehealth, telemedicine ventures out there. You've got players like American Well and Teladoc, and Doctors in the Mind just raised $75 million yesterday. You've got a bunch of underlying tech video companies like VC and Video. So we need more.
I mean, in fairness to those companies, I won't say they're bad technology, but they're technology that's predicated on serving needs that weren't necessarily the needs of the marketplace as a whole. The two things that we didn't see that we wanted were, one, the ability to bring in your own experts when you need them. Many of these solutions are predicated on the idea that they're there to sell you their resources, which is fair because that's how they make money. But it isn't necessarily a good thing when you want to staff up your own in-house telehealth system, or ideally one that's a hybrid ecosystem between in-house and out-of-house. The second thing we didn't want to do was hire a bunch of people to sit around in a call center and connect the dots. We wanted this to be very much an automated, extraordinarily high throughput system. And that's what we couldn't find out there, were these workflows that could be extremely quickly adapted to many different scenarios we hit out there in the marketplace.
So you've been now in the your second company. I think you're the first person with a second company in the newly renamed digital health marketplace, which is the successor, or the same thing basically as the New York EDC Pilot Health Tech venture, which Health also runs, full disclosure. And you've been working there with the Jewish Home, is that right? The Jewish Home?
That's right. The New Jewish Home now.
New Jewish Home, yes. So give me a sense of what problems you were solving for them, and then tell me a bit more about some of the other customers that you now have on the system.
Yeah, for sure. So the New Jewish Home theorized, and I think correctly so, that a lot of the work they do in skilled nursing is effectively stepped down from somebody in the ecosystem that's upstream from them, like a hospital partner. And their goal was to prevent a readmission back into the hospital and ultimately save costs systemically by providing on-demand access to both clinical and more tactical expertise, so that that nurse who encounters the bedside can actually deal with the patient appropriately. So we staffed up doctors, we provided in the same portal access to physicians, to interpreters, and really equipped these folks that were working with the patients to quickly triage a situation and prevent that readmission. And those go for about $10,000 a pop. So it was a good project.
And then tell me a bit more about some of the other services and by definition also customers on the system, as you're a system and you're linking up different parts of both provider organizations and people like interpreters and others doing services. So who else is on the system? What kind of other things are happening?
Yeah, for sure. It's interesting because when you think about this on-demand approach to healthcare, it's typically got to be things where you don't need a deep relationship with the provider and you can cover off on these things quickly and have an impact. So those use cases, of course, interpreting is a huge one. But more importantly, combining interpreting with real healthcare workflows in the clinical sense. So we've done some really neat things with providing on-demand access to behavioral health in multiple states. So this is a complex provisioning process where you've got psychiatrists all over the country that hold credentials and licenses in multiple states and multiple health systems. And we're clearing at the ED or at the bedside or in a clinical sense, within 30 seconds typically, getting somebody access to a psychiatrist that's going to potentially prevent an admission into the hospital or get these folks the help they need in an FQHC without having to actually be committed to an institution. So that one's really neat. The impact is immediate. We're also doing some really great work with a group called MedStar Health in the referrals process. So they've got an excellent transplants group, and we're equipping their customers and their partner organizations to interface with transplant surgeons and the care team on demand 24/7 so they can actually shepherd a patient through that process very smoothly. And then, some of the more tactical things we do, wound care, med management, really anything where you might equip a point of care provider with all of the tools so she's effectively the smartest person in the room.
So organizationally wise, you and Matthew started this company a couple of years back. You've been, I would say, somewhat under the radar.
Oh, yeah.
I think you're having a little bit of a coming out party this week. You're going to next end of this week, and next week you're going to the ATA conference in Chicago. A lot of conferences on today. That's Health Data Palooza. Health has its Dead for Health. I think next week. The ATA is the big one in the sort of telemedicine, telehealth space. Chicago this weekend and next week. What can people expect to see there if they meet you?
I think, come by the booth. We can show you the system. We'll show you the ecosystem of experts we've collected onto this system. And if you're a healthcare organization, we'll show you how to leverage your own resources and actually create interventions on the fly. If you're a third-party provider, a telehealth vendor, maybe, we'll show you how to get into this ecosystem very fast and very easily.
That's exciting. One last thing before you go, Brian. We talked offline, and you said that one of the things you're anticipating is a growth of a much bigger ecosystem. How do you think this is going to change the ability to do that? It's going to change the relationship between what are now providers and suppliers and specialists. What do you think things going to look like when your ecosystem is full up and fully deployed?
I think the look and feel for the provider at the point of care won't change, or maybe it'll get easier to access specialties. But for the folks that are managing large organizations like a MedStar or UW or Nebraska Health that are using our platform, what this enables them to do is really put out these service level protocols that are top notch, because it's almost like selling an airline seat. They can over deliver or overpromise because they always know they've got 24/7 backup to these third parties they can spill over to if needed. So it's a nice scenario that as every customer goes live, they both become a node to consume resources and a node to provide resources. And we already have, I can't tell you who they are, but we have customers that literally compete head to head. And behind the scenes, they're sharing maybe 20% of their volume across our platform, unbeknownst to their end customers.
All right, it's an interesting way to think about how technology is going to change the shape of how organizations provide care and hopefully make it much more accessible to the end consumer, the inpatient, and that's the overall our goal. All right, well, we'll wrap it there. I've been talking with Brian Yarnell. He is the president. I don't want to insult Matthew, the other Matthew, the president of Bluestream Health, and he'll be at ATA in the coming days, Sunday through Tuesday, I think. So looking forward to catching up with you there, Brian. And thanks for coming on THCB today.
All right, thank you.